Because PDSA is not a one-and-done type of deal. It's iterative.
This is Stepping Up Healthcare. Your host is Tack, and the mission is simple. Build your capability and curiosity to make healthcare better.
Welcome back. Last time we talked about plan and do, and why PDSA is not D, or do. We focused on how to move from just trying things to creating a hypothesis statement and actually testing changes with intention. Today we're going to be picking up from where we left off, with the S and the A, that's study and act, as part of PDSA. Now, teams can do a decent job with planning. Some teams even run small tests of change. But then what? They stop short of real learning. They either skip the study step completely, or they jump straight into implementation and spread without adapting. And that's how we convince ourselves something worked when maybe it didn't. So let's start with study. Study is where you compare what actually happened to what you predicted would happen. Not just, did it work, but did it behave the way we expected? This is where we bring back the idea of a hypothesis. Remember your if, then, as measured by statement? This is where you evaluate it. You're asking against your hypothesis statement, or you're asking a couple of questions like, what were our results? How do they compare to our prediction? What did we learn? And what surprised us? That's always a fun one, to see what surprised you along the way. Now, that might come in a variety of different ways. It could be a simple count, a percentage, or even just qualitative observations. You don't necessarily need perfect data, especially if you're just doing a small test of change. Just something quick and dirty is going to be good enough. You just need that honest reflection. After that comes ACT, the A in PDSA. This is where you decide what to do because of what you learned. There are typically 3 paths that you follow. The first one is adopt. The change worked as expected, so let's expand it. Maybe the first time we just did it on one patient, so now we're just going to do it in one unit. Or maybe we're going to spread it across the whole hospital and see what happens. Next is adapt. It partially worked, so you may want to tweak it, test it again. Maybe you still expand a little bit. Maybe we do a handful of patients rather than just one this time. And lastly, abandon. It didn't work, so let's try something else. And that's the key here. We learned what didn't work, so now we can try different paths. Another key idea, though, is that ACT is not about just rolling things out. It's about deciding what our next test of change is going to be. That's a big mindset shift for most people, because PDSA is not a one-and-done type of deal. It's iterative. It is purposefully cyclical. Even if you adopt the change, the next test comes from, now that we've expanded, are we still getting the desired result across all areas? Or maybe, how do we improve even further? Thinking about that continuous improvement mindset. Or lastly, are the things we made sustainable? That's a really good insight too. Even though we got good results and we implemented this change, can we continue to do it? The key point in all of this to remember is that PDSA is the journey, not the destination.
Why does it matter?
This is where improvement work either becomes powerful or just compliance. Without S or study, a variety of things can happen. First, you rely on opinions instead of evidence. You're just running off vibes rather than actual results. Number 2, you mistake activity for impact. In other words, just because work was done doesn't mean there was improvement. And number 3, you might miss important insights. May have gotten the results we wanted, but the process getting there was incorrect or possibly even unsafe. Now, without ACT, or the A in PDSA, learning doesn't go anywhere, tests don't evolve, and and there's no innovation. In other words, we don't reflect after our experiment what actually happened and how can we make it better. All of these have real consequences, because we're not just optimizing workflows or just trying to save money. Ultimately, we're impacting patient safety, patient experience, staff satisfaction, even staff development. If we skip study, we risk reinforcing half-baked processes or not really having any real lessons learned. If we skip A, or ACT, we risk only applying band-aid solutions and don't explore what else might be true or what else might even be possible. A strong study and act phase turns data into insight, insight into actions or countermeasures, and those countermeasures into improvement.
Let's talk about some real-world examples.
Let's say a unit is testing a new AVS explanation or an after-visit summary. So starting with study here, we predicted that if we implement this new AVS process, then we expect patient satisfaction to improve as measured by an increase in HCAHPS. Now, granted, maybe HCAHPS isn't the best metric to look at, especially on a small scale, but we're going to let that slide this time. So, what actually happened, so comparing to what we predict would happen to what actually happened, the actual shows scores didn't change much. But observations and interviews showed nurses felt more engaged and patients asked more questions. That's interesting. The initial metric didn't move, but some of the intangible things did. That is a very interesting learning. So, moving into our ACT, our A, instead of abandoning the idea and scrapping the whole project, let's adapt the test. Maybe we need to refine how nurses introduce the process to the patient, or maybe adjust the timing and the scripting, or give the patient something to write on and take notes when applicable. Then run another cycle. Next example, let's say we're looking at sepsis screening in the ED. So a triage nurse tests a new screening tool for sepsis. So what we're trying to predict is that compliance will increase. So our study shows that compliance increased. Great. But triage time also increased. Not great. Now you have a trade-off, not a clean-cut win or loss. So moving into our ACT, we decide to adapt. Maybe simplify the tool, asking what are the actual important and appropriate questions? Can we trim any of them off? Or we integrate it better into the workflow. Think about how it's sequenced as we're seeing these patients in triage. Then we test again, and still on a small scale. Last example. Talk about fall risks. So our prediction. If we implement a standard to have all alarms on high sensitivity, then we expect less patients to fall as measured by a decrease in our monthly falls. Once again, maybe not great metric just because you have to wait a whole month for that data. Maybe it's just a week or a couple of days. Nonetheless, we move on to our study. Bed alarms are going off more, but falls have not decreased over the test period. So part of our adjust is maybe we abandon this. We need to try a different countermeasure, because through interviews and observations, we learned that bed alarms don't actually prevent falls. They only tell you when someone is getting out of the bed. There's still that reaction time between when the alarm goes off and us getting to the patient. So let's decide on what we're going to try the next PDSA cycle. So let's talk about variation for a moment. Across all industries, including healthcare, not every change in data means something meaningful happened. Sometimes results shift due to normal fluctuation. We call this common cause variation. Other times, something in the system actually changed. We call that special cause variation. Study is where we begin to ask, is this a signal, special cause variation, or just noise, common cause variation? Even simple tools like run charts or basic before and after comparisons can help you start to see patterns over time. Best practice is using control charts to sort out the noise and the special cause variation. Not going to cover control charts in this episode, but there's another layer here, and it's not one we often talk about. When there's pressure to show results, whether it's from the executives, whether it's from your health system, whether it's from just your boss, it can be tempting to shape data to tell a more favorable story. Maybe it looks like choosing a timeline that makes the numbers look a little better, or highlighting one metric but ignoring others, or stopping measurement right when things peak. This is sometimes referred to as data manipulation or data massaging. And it doesn't have to be intentional to be harmful. And here's the real problem, in my opinion. When we massage the data, even a little, we break the learning cycle. To be clear, not blaming folks who do some of the data manipulation, just calling out that they are robbing themselves of a chance to truly learn about what we've been experimenting on. We start making decisions based on what we want to be true, instead of what is true. We are looking to confirm, either intentionally or unintentionally, any bias we might have. That can lead to scaling things that don't actually work, missing unintended consequences, reinforcing processes that need a little more refinement or just half-baked ideas, and most importantly, setting ourselves up for failure and frustration further down the road. A strong study isn't about proving success, it's about understanding reality. Because the goal of PDSA isn't to look good, it's about getting better and learning. So continuing to bring it back, when you're in the study phase, ask yourself, what did we learn? That one question can completely change how you interpret your data and how you adjust it, or the A act. If plan and do get you started, study and act are what make improvements real. They are what turn effort into learning and learning into better care for our patients. So the next time you test a change, don't stop at, we tried it. Try asking yourself, what did we learn and what will we try next? That's where improvement actually happens.
Homework time!
All right, it's homework time. Let's keep this pretty practical here. Last time I asked you to plan and do something. Now I want you to study and act on it. So do the whole PDSA cycle. Or you can start over with a new plan and do. Up to you. The goal is to do a full PDSA cycle. That is your homework assignment. As you get to the second half of PDSA, the study and act part, ask yourself a couple of these questions. So for study, what did we expect to happen? And what actually happened? And be honest, it's only a failure if we haven't learned anything. Even if it goes wrong, or we didn't get the results we wanted, it's about learning. Now, moving on to the act part, we need to decide, should we adopt, adapt, or abandon it? After that, decide what your next PDSA cycle might be. If you want extra credit, do your second cycle of PDSA afterwards as well. Well, that's all I've got for you today. Next episode is going to be about Gemba and creating the current state. Until then, I'm Tack, you're appreciated. Let's step up healthcare.